You know, three countries reduce antimicrobial resistance rates while maintaining patient outcomes. The Netherlands cuts methicillin resistant staph aureus to below 1%. Sweden achieved the lowest antibiotic consumption in Europe. Thailand reduced carbapenem resistance by 40%. Evidence-based solutions work. Welcome to another episode of Global Health Decoded. I'm Dr. Anthony Iyure Anavyokai. On this channel, we decode global health through evidence-based analysis, one crisis, one solution at a time. Do take a moment to like, subscribe, and share to get the YouTube algorithm going. Let's get to it. Now, this content is educational. It's based on WHO 2024 to 2025 data and CDC reports. It is not medical advice. For antimicrobial prescribing or stewardship implementation, please consult qualified healthcare professionals and infectious disease specialists. The Netherlands. Search and destroy. The Netherlands maintained the lowest rates of methicillin-resistant Staphylococcus aureus in the world, consistently below 1% of all S. aureus isolates. This achievement stems from a comprehensive policy known as search and destroy, implemented nationally since the 1980s. Netherlands MRSA rates less than 1%. Methicillin resistance staph aureus rates less than 1%. Now, the policy operates through systematic screening and containment. All patients admitted to hospitals from high-risk categories undergo MRSA screening. Those transferred from foreign hospitals, healthcare workers from countries with high MRSA prevalence, patients with previous MRSA history, and those from farms with livestock exposure. Screening occurs through nasal swabs and wound cultures when applicable. Patients testing positive or awaiting results are immediately placed in contact isolation. These are single rooms with dedicated equipment and strict hand hygiene protocols. Healthcare workers caring for these patients use PPEs. The patient remain isolated until three consecutive negative cultures confirm that methicillin-resistant Staph aureus clearance or until discharge. Treatment with decolonization protocols using tropical mupirocin and chlorhexidine bethine attempts to eliminate carriage. The approach extends beyond hospitals. Long-term care facilities, dialysis centers, and other healthcare settings implement similar protocols. Veterinary medicine participates too. Livestock farmers and veterinarians receive education about methicillin-resistant Staph aureus transmission pathways between animals and humans. The economic investment proves substantial. Screening, isolation facilities, and personnel time requires resources. However, the cost-benefit analysis demonstrates net savings. Preventing MRSA transmission reduces expensive infections, reduces extended hospitalization, and reduces complicated treatments. Studies, in fact, estimate that maintaining low MRSA prevalence saved the Netherlands approximately 150 million euros annually compared to costs that would occur with prevalence rates typical of other European nations. Critically, patient outcomes remains excellent. Concerns that aggressive screening and isolation might delay necessary medical procedures or compromise care quality proved unfounded, fortunately. Mortality rates, surgical complication rates, and other quality indicators match or even exceed those in countries with higher MRSA rates. The Netherlands model demonstrates that maintaining low resistance through prevention costs less than treating resistant infections after they become endemic. As the proverb says, an ounce of prevention is worth a pound of cure. Second model is from Sweden, the sustainable low consumption. Sweden consistently demonstrates the lowest per capita antibiotic consumption in Europe, approximately 10 defined daily doses per 1,000 inhabitants per day. This achievement results from sustained public health campaigns, from prescriber education, and from cultural shifts towards judicious use. A nugget for you: Sweden, lowest antibiotic use in Europe. In fact, the Swedish strategic program against antibiotic resistance was launched in 1995 and continuously updated. It coordinates activities across human medicine, veterinary medicine, and agriculture. The program emphasizes that antibiotics are precious resources requiring careful stewardship rather than routine commodities. Public education campaigns prove central to success. Strama, the Swedish strategic program, conducts annual awareness campaigns explaining that viral infections do not respond to antibiotics, that inappropriate use drives resistance, and that preserving antibiotic effectiveness protects future patients. TV adverts, social media content, and primary care materials reinforce these messages. Prescriber education occurs throughout medical training and continuing professional development. Swedish medical students receive substantial instruction on antimicrobial resistance, on appropriate prescribing, and on diagnostic approaches to distinguish bacteria from viral infections. Practicing physicians participate in regular training updates. Clinical guidelines emphasize narrow spectrum antibiotics, short treatment durations, and watchful waiting approaches whenever appropriate. Crucially, the healthcare system supports this practice. Swedish primary care physicians face no financial pressures to satisfy patient demands for necessary prescriptions. The universal healthcare coverage eliminates concerns that patients cannot afford return visits if symptoms persist. Time allocation allows thorough consultations where physicians can explain why antibiotics are unnecessary without feeling rushed. The results extend beyond prescription volumes. Sweden maintains low resistance rates across multiple organisms. Penicillin-resistant Staphylococcus pneumoniae remains rare. Extended spectrum beta-lactamase producing Enterobacteriaceae occur at rates well below European averages. Patient outcomes remain excellent. Life expectancy in Sweden ranks among the world's highest. Infant mortality rates are exceptionally low. The concern that reducing antibiotic use might compromise health proved unfounded. Appropriate use optimizes outcomes. This Swedish model shows that cultural change supported by education and healthcare system design can sustain low consumption over decades. Move to the next model, Thailand, the National Action Plan implementation. Thailand developed and implemented a comprehensive national strategic plan on antimicrobial resistance in 2017, achieving measurable progress in reducing resistance rates while strengthening healthcare system capacity. The plan exemplifies how middle-income countries can effectively address AMR despite resource restraints. Another nugget for you: Thailand, 40% reduction in carbapenem resistance. You see, the Thai approach integrates One Health principles across human health, animal health, and environmental sectors. Antibiotic use in agriculture faced particular attention. Thailand became the first Asian country to ban antibiotic growth promoters in livestock production. Veterinary prescription requirements for all antibiotic use in animals were implemented. Farmers received training on alternative disease prevention methods, including biosecurity, including vaccination, and including improved husbandry practices. In the sphere of human medicine, the National Antimicrobial Resistance Surveillance Center expanded laboratory capacity for culture and susceptibility testing. Hospitals throughout the country submit data quarterly. This surveillance identifies emerging resistance trends and guides treatment guideline updates. Antimicrobial stewardship teams were established in all public hospitals. These teams implement prospective audits and feedback. They develop facility-specific guidelines based on local resistance patterns and educate prescribers. The Ministry of Public Health provided training and resources to support these programs. Public awareness campaigns utilize mass media and social media platforms. Messages emphasize completing prescribed antibiotic courses, not saving antibiotics for later use, and not sharing antibiotics with others. Pharmacy regulations restricting over-the-counter antibiotic sales were strengthened and enforcement increased. The results demonstrate impact. Between 2017 and 2023, carbapenem resistance in Klebsiella pneumoniae decreased from 28% to 17% in tertiary hospitals. That's a 40% relative reduction. Extended spectrum beta-lactamase production in E. coli stabilized after years of increases. Antibiotic consumption in hospitals decreased by 15%. Thailand's success proves that comprehensive national action plans, adequately resourced and politically supported, can reverse resistant trends even in countries without high-income healthcare systems. The evidence encourages other middle-income nations. So what are some of the common success factors? Well, despite different approaches and contexts, the Netherlands, Sweden, and Thailand share critical success factors that inform strategies for other countries attempting to reduce antimicrobial resistance. In fact, success factors was based on a trifold of leadership, data, and coordination. We take the first one, political leadership and sustained commitment. All three countries implemented policies supported at the highest government levels. Leadership remained consistent across election cycles and administrative changes. This continuity enabled long-term strategies rather than short-term initiatives. Second, robust surveillance systems providing data to guide decisions. The Netherlands tracks MRSA meticulously. Sweden monitors antibiotic consumption and resistance patterns comprehensively. Thailand expanded laboratory capacity to enable surveillance worldwide. Evidence-based policy, after all, requires, well, evidence. Third, coordination across sectors. The One Health approach, integrating human health, animal health, and environmental considerations, proved quite essential. Siloed interventions targeting only human medicine achieve limited impact when 70% of antibiotics are used in agriculture. Fourthly, adequate resources were allocated to implementation. Political commitment without funding accomplishes little. All three countries invested in surveillance infrastructure, stewardship programs, laboratory capacity, and personnel training. These investments yield returns through reduced healthcare costs from resistant infections. Fifth, cultural adaptation. The Netherlands' aggressive screening reflects their healthcare system capacity. Sweden's approach emphasizes education fitting their cultural context. Thailand's strategies address challenges specific to their settings, including over-the-counter antibiotic access. Successful interventions adapt to local contexts rather than importing foreign models unchanged. As the management consultant Peter Drucker rightly observed, culture eats strategy for breakfast. Effective AMR responses requires both strategic planning and cultural change. So what are the lessons for global implementation? Now, the success stories provide actionable lessons for countries at various stages of AMR response. No country must wait for perfect conditions before beginning. Incremental progress compounds over time. In a word, start where you are, use what you have. For low-income countries, Thailand's experience proves particularly instructive. Comprehensive national plans need not require high-income resources. Prioritizing interventions based on feasibility and impact enables progress within constraints. Strengthening laboratory capacity, implementing stewardship programs in tertiary hospitals first, and regulating agricultural antibiotic use represent achievable initial steps. For middle-income countries, scaling Thailand's successes while incorporating elements from European approaches offers pathways forward. Regional cooperation can pool resources and expertise. For high-income countries, the Netherlands and Sweden demonstrate that maintaining low resistance requires sustained vigilance. Complacency when rates decline risk resurgence. Continued investment in surveillance and stewardship proves essential. The fundamental lesson here is that antimicrobial resistance is not inevitable destiny. Evidence-based interventions, adequately resourced and politically supported, can reduce resistance while maintaining or even improving patient outcomes. The question is not whether solutions exist, but rather whether countries would implement them. I'll give you another quote. As anthropologist Margaret Mead stated, "Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has." So here we have it. What successful AMR interventions have you observed in your country? Let's share examples that others might learn from. In conclusion, we'll just say the Netherlands maintains MRSA rates below 1% through systematic screening. For Sweden, it achieves Europe's lowest antibiotic consumption through two things: education and culture change. In Thailand, there was reduced carbapenem resistance by 40% through national coordination. 3 countries, 3 approaches, 1 conclusion. And that is that evidence-based interventions work. Success requires political commitment, requires adequate resources, requires robust surveillance, and sustained implementation. The solutions exist. The evidence is clear. Will we act? Next episode, look at action plan. Whether you are a healthcare professional, policymaker, researcher, or concerned citizen, evidence-based actions exist for your context. Do not forget to subscribe to Global Health Decoded. We're on Instagram, TikTok, Facebook, LinkedIn at Global Health Decoded. In the next episode, we'll look at your action plan. Now tell me, did we nail this one? Maybe, maybe not. But as always, fact checked, peer reviewed. Dr. Anthony Ray and now Yokai. See you next time.